All right, welcome everyone to the HV Impact webinar on maximizing caseload capacity in MIECHV. We will today be hearing from awardees who will share successes around this particular focus for moving our performance measures ahead. I'd like to just start by introducing you quickly to the room. If you would like to go over to the chat on the left and introduce yourself, let us know who you are, where you're from, and what your position is within MIECHV, that would be great. I'll just let you know that if you need to leave our webinar early, we would ask that you would take the evaluation survey link and copy it into your browser so you can complete the survey. If you leave before the final slide, then you will not get the survey to come up automatically, and we really do value your feedback. The next box you'll see is for audio, so hopefully you're hearing my voice and you'll be able to call back in if somehow your connection gets cut off. And then finally, if you have any technical issues during this presentation, please do go to the technical support box and type in your questions. We will be making this presentation available in PDF, and also it will be on the HRSA website along with the 508 compliant version and the transcript very shortly after this session. So with that, I'd like to get started. My name is Karen Chiron. My picture's in the upper left-hand corner, and I'm the Universal Technical Assistance Manager for HV Impact. Today, we will be going through several different presenters from different awardees across the country, and they'll be sharing their thoughts and successes and ideas with you. But during the course of the presentation, we would ask that you use the chat feature to the left to ask any questions that you may have of our presenters. We'll be able to have some time for Q&A throughout the course of the session, but also at the end, we've saved some time as well for questions that may build up. We will be recording this session, as I mentioned, and we'll make sure that all of this information is available on the HRSA website as soon as we can. So moving ahead, I want to just again remind you we do value your feedback, so you will be prompted immediately after the webinar to complete an evaluation. And we would ask that you take just a couple minutes and answer those questions so that we could continually improve the resources that we put forth. Today, during the course of the webinar, our objectives will be to learn about various MIECHV awardee success. We'll hear Alabama talk about quality being more important than quantity in building sustainable community relationships that result in and support long-term home visiting caseloads. Pennsylvania will talk about finding success through use of enrollment improvement plans, tiered supports, and family support for local implementing agencies' cyclical monitoring tool and a process that they use to do so. Florida will share their experiences about using a learning collaborative approach for building a coordinated intake and referral system to increase their enrollment. Georgia will share about how to maximize caseload capacity through contract monitoring. And finally, Tennessee will share their lessons learned during a multi-stage CQI project around length of retention. So we hope that you'll find this very valuable and you'll ask lots of questions of our presenters as we go forth. Our presenters for today, from Alabama, we have Heather Johnson and Diana Toulier. From Pennsylvania, we have Andrew Diaz. From Florida, we have Allison Parrish. From Georgia, we have Natasha Worthy. And finally, from Tennessee, we have Carla Snodgrass. So with that, I'd like to start by turning it right over to our presenters from Alabama, who will present first.
Thank you. This is Diana. Just kind of wanted to start out a little history. I think in Alabama from 2010 to 2014 with the initial receipt of MIECHV funds, I think we didn't know quite enough about home visiting in our state. So really there was more of a focus on quantity than quality. I think our programs probably did not have a lot of guidance when they were setting their initial capacities. So as a result, from 2014 to 2016, we had some state-level staffing changes. And this really caused us to take a close look at the fact that our programs were not consistently meeting their 85% capacity benchmark, and we were not meeting that benchmark as a state either. So that was really kind of what led to us looking more closely at both the quality and the quantity of our programs. So reputation, when we contract with programs who serve more than one county, they know that there is a county-specific capacity expectation. So initially, a lot of our programs were holding spots open in some counties, like some of their more rural outlying counties, while maintaining waiting lists in their more primary counties. So what we did is we asked them just to stop doing that so that they could reach their overall goal of 85% enrollment. And when I felt like when that stress was lifted off of the program, they were able to focus more on their community outreach and establishing relationships in the communities. And ultimately, that ended up leading to an increase in referrals. So I'm sure most states have programs that serve multiple counties, and your larger counties fill up and you get more referrals, and it's the outlying counties where you have to travel and you can't always find staff to hire in those, staff that are embedded in those counties. So they're just harder to serve overall. And the other thing that we found was that when the programs did fill up, it kind of led to a decrease in referrals, because referral sources, especially physicians, we found out, get really frustrated when they make referrals to programs only to be told that their people are going to be put on the waiting list. They're less likely to make referrals in the future if they think that they're just going to be placed on a waiting list. Our state has been really fortunate in the last 12 months. We have gained additional funding from 3 brand new sources. Up until then, we really only had MIECHV funding and a little bit of state funding from our Education Trust Fund. So it began with Governor Ivey's infant mortality reduction initiative. So Alabama has one of, if not the highest infant mortality rate in the country. So our Department of Public Health looked at the data and named 3 counties as having the highest rates in the state. So we already had some established home visiting in those 3 counties. However, the model that the governor was most interested in was nurse family partnership, and we only had that in 2 of the 3 counties. So with the funds that we received, we added home visiting using the NFP model in 2 of the counties and expanded NFP in the county that already had it. So adding a more medical model in 2 of the counties has been somewhat easier since nurses are involved. However, it's still been challenging since NFP eligibility criteria is so narrow. One county is extremely challenging all the way around. I don't know how many other states encounter this, probably everybody, but it's a county that borders another state, and pregnant women and families receive medical services in both states since there are agreements with Medicaid and insurance companies. So it's further complicated by a large transient military presence. So a large portion of those families go on the military post for medical services and support. Enrollment in that county has been slow. The programs have struggled to keep families engaged once they've enrolled them. They've done tons and tons of public awareness. They have partnerships with Head Start, relationships with Medicaid care coordinators. I feel like they just think maybe, kind of wonder why they got home visiting training, because really they needed, marketing and public awareness training instead. But things are looking up. It's very slow progress, but it's steady. And then I think our biggest bonus was when Alabama Medicaid became involved. And we asked them if they would consider providing matching funds for the state funds that we were getting for home visiting. And they did agree to match both the funds that we were spending on both nurse family partnership and on parents and teachers. So that was really, really exciting. So that has given us another pot of money to expand some services into other counties where there was no home visiting. And then also, we're working with the Department of Human Resources on some other projects, and home visiting happened to come up in conversation. So they actually decided to contract with us to fund home visiting in about 9 counties that did not have any funded home visiting through our program. I think a couple of them may have had some other home visiting, but it just wasn't funded through our program. One of the things that we found is really successful is that we first approached existing programs when we wanted to expand. So if we had a program that touched a new county that we wanted to go into, we would reach out to the existing program. I think we can all agree how expensive it is to train new home visitors. So we definitely knew that it would be more cost effective just to start with existing programs. The other thing is to make sure to include training costs and startup costs for new counties and allow adequate time for model training, recruitment, and enrollment. There's no golden timeline for that. You just really have to, have frequent contact with the program and just make sure that you're supporting them the best way that you can, and really just accept and encourage them, because they're doing the best that they can. They can't make people enroll in the program. They certainly can't make them stay in the program, especially when you're going into more rural areas where, people, they don't know who you are. They don't know if you're going to report them for some sort of, because their house is a wreck or, the conditions that they live in. So it just takes a while to build up that trust. So I'm going to hand it off to Heather Johnson. Heather is part of our research and evaluation team at the University of Alabama at Birmingham. And I'll let her talk a little bit more about the support they provide for our programs.
Thanks, Diana. I'll just start right away with the fact that we train all home visitors and supervisors. Initially, it's 3 days of training, and so we think it's really important that everyone start off with the same knowledge base with respect to home visiting. So we talk a lot about, not only what it's like to be a home visitor, not only what it's like to be in the home with a family, but we also go over all of the assessments and the benchmarks, and we talk a lot about ETO, and in Alabama we do use efforts to outcomes for our data entry. And then we discuss all the blank forms that Alabama has created to match our ETO database. And so in addition to that 3-day training, we really tried to support our supervisors and our home visitors with technical assistance and training on an ongoing as-needed basis. So we talk a lot in the training about how this is not a one-stop training. We don't expect that they leave with an understanding of all of the data collection requirements. It's a lot. And so we recognize that they're very overwhelmed initially. And so we try to start building that with some follow-up. So we reach out on our part to make sure that they feel supported, but we also really do hope that they'll email and call us. And when we do receive those emails and calls, we are extremely responsive, and we feel like that has helped to build that trust with the program, and that they then feel comfortable moving forward, that they can come to us when they don't understand something, or when things get confusing, which inevitably they will get confusing. So that's sort of our overall policy. Also, it's really important, as you all know, to monitor the programs, especially as you have new programs that are starting up. We do expect that oversights happen, missing data clearly happens, and again, it gets very confusing. So we want to make sure we have infrastructure for monitoring. And so we have a plan in place whereby sites are sent monthly reports that bring attention to their missing and or their suspicious data. So we do, for each individual site, we do monitor data on a monthly basis. And we have a laundry list of reports that we run every single month that we look over. And then we compile all of the reports into one report that is sent to each individual site, to their site managers or their lead parent educators. And they're able to see exactly what we see in terms of missing data or potentially problematic, incorrect data. And they're given an opportunity to correct that in the database. And then in the following month, we'll check again to see, was that information in fact corrected, or do we need to discuss it again? So that happens every single month by the 15th of the month. And so sites know to look for that report between the 10th and the 15th. We've also started to look at the DGIS report 2 times a year. So we compile a mid-year DGIS report as well as our required end-of-the-year DGIS report. And we break that information down for each site. And so we send a DGIS report, we call it the mock DGIS, but we send that report to sites mid-year.
And that allows them to see that if we were to run the DGIS report, mid-year, what would their data look like? How much missing data would they have? And we also started about 2 years ago providing Excel spreadsheets with all the missing data. So, for example, if there were sites that were missing their depression screening for certain clients, we send them a report that shows the client number, the date that the screening should have occurred, and that way they can see, who the home visitor was and what happened, and if it was a data entry error, it was an oversight, they have the opportunity to correct that. And if it was missing data, they can look for trends and see if there are training needs, for certain home visitors or different things that we can really specifically focus on to improve the numbers from mid-year to the end of the year. And the last couple of years that we've been doing this, it absolutely has improved our numbers. We found that, giving sites the opportunity to do, sort of a low-impact, trial run has been really, really helpful. We also use Zoom because we're obviously spread out throughout the state, and we recognize that traveling to one centralized location can be expensive, but we use Zoom calls to really do meetings where we go over the reports and we provide them with supporting documentation and detail. And we really have a focus on, in our state, how do we use data to improve our our services to families. So always trying to frame it in that way, and that has helped our programs as they've come alongside us. Diana?
Yeah, I think we're a little over our time, so I'll just go through this one really quickly. We grant funds to programs up front. We don't do reimbursement. The program sends us spreadsheets monthly, expenditure spreadsheets monthly. So we feel like maybe that they have a little less staff turnover. We have an annual grant process that includes very specific program assurances so the programs know exactly what we expect of them. And it also allows programs to make changes annually. If they've decided they have had it trying to serve a rural county that they cannot enroll any families, then we can offer that to another program if needed. But that's about it. Thank you.
All right, Andrew from Pennsylvania, would you like to start? And our presenters, you have a question in the chat. If you want to head over to the chat, you can answer it over there for everyone to see. Go ahead, Andrew.
Sure, absolutely. So a little bit of background about Pennsylvania. So Pennsylvania, our family support and home visiting programs sit within the Office of Child Development and Early Learning, which is overseen by both our Human Services and Departments of Education. So within OCDEL, which we call it OCDEL, so it's Office of Child Development and Early Learning. I'll be referring to it as OCDEL. Under OCDEL, we have the Bureau of Early Intervention Services and Family Supports, which is provides our state-level technical supports to our family support and home visiting providers. We have a variety of staff located in OCDEL and through contracted business partners that help us provide TA to the local implementing agencies. Staff includes data analysts within OCDEL, 2 fiscal specialists, one of the 2 at our business partners at the PAP, and the second one is within OCDEL. 3 family support consultants, which are the direct contacts for our local implementing agencies. So each LAA is assigned to a family support consultant, and that's the first person they go to, and we have 3 across the state for all of our programs. 1 CQI program specialist who also is housed within OCDEL, and our needs assessment evaluation team, which we've contracted out for our needs assessment to Children's Hospital of Philadelphia Policy Lab. So currently our MIECHV funding supports 4 different evidence-based home visiting models across 30 local implementing agencies. So we have Parents as Teachers, Nurse Family Partnership, Healthy Families America, and Early Head Start. And then in addition, we fund 2 additional evidence-based home visiting programs, Safe Care, Augmented, and Family Checkup through our state funding, which aren't on the slide. So since the beginning of our MIECHV award from 2010, Pennsylvania has had the requirement that all of our MIECHV local implementing agencies maintain a program enrollment of at least 95% over a 3-month average. So we looked over 3 months instead of monthly to determine that it was at least at 95%. The thought was to set the expectation higher than the MIECHV requirements in order to meet the minimum of 85% throughout the entire state. The expectation is stated in the contract with our family support providers, and you can see some of the language here. We did change it. This is new language, so we did change that if it falls below 90%. It used to say 95%. We lowered it a little bit from past years. This is new language moving forward that's actually included in our contracts that the state has with all of the local implementing agencies. Through close monitoring and state-provided technical assistance, MIECHV-funded programs have consistently met the minimum enrollment threshold of the 85% and usually get to 90 or 95%. Each home visiting program is designated to family support consultant, as I mentioned earlier, and the consultant is responsible to provide ongoing monitoring and cyclical site visits and recommendations to help them improve enrollment. So for enrollment or program capacity, programs are required to report their enrollment actually monthly to their family support consultant on a designated report. The report was initially in Excel and actually has moved to our family support data system, which we've built over the past few years, and I'll show you that in a minute. Each year during contract renewals, or if we have a competitive application process, depending on the year, we have the local implementing agencies update their family capacity as part of the renewals for the contract. That way we can talk with them and negotiate on the number of families they plan to serve as a capacity. This was the original enrollment report here on the slide. So in the past, it was entered into an Excel document, and that each agency then submitted to their family support consultant via email. So this enrollment included the current family slots filled compared to the slots funded, any barriers to filling funded slots, and any updates to the barriers or any comments they had around staffing or issues with filling their families. Programs also noted the number of children being served and the amount of families and children served to date, so the cumulative numbers for families and children. The report was submitted by LAA to the family support consultant by the 5th of the following month, so the report for July 2019 would have been due technically August 5th, 2019. And then once they were reviewed by our family support consultants, they were then forwarded to our family support and CQI program specialists who then put them all into one giant Excel report. And then we, at Oakdale, we have what's known as our Family Support Steering Committee. So all of those people I mentioned, our data, our fiscal, our family support consultants, myself, some of the other leadership at Oakdale have monthly meetings where we meet to discuss any issue with any of our LAAs in MIECHV or our state-funded LAAs, which we have about 90 programs total now across the state and federal funding. And then so starting actually July 1st of this year, we've actually moved away from, well, technically starting our state fiscal year, which was July 1st of 2018, we moved away from the Excel report and built this report into our data system. And then starting in September of this year, we actually plan to have the report calculate based on the data we're collecting from all of our both MIECHV-funded LAAs and state-funded LAAs. We're collecting the same demographics and performance measures across all of our programs as of July 1st, 2019 now. Additionally, what this was that every LAA, if they fell below the threshold of the 95%, they were placed on an enrollment improvement plan. That'll be 90% moving forward, pending a review of any extenuating circumstances. So we did have some where we didn't place them on a plan due to some circumstances outside their control. If an enrollment improvement plan is needed, the family support consultant will meet with the LA and work with them to create a realistic plan to reach their 95% goal. We're also lucky enough in Pennsylvania to have a state office for parents as teachers and two nurse-family partnership nurses from the National Service Office that are dedicated to MIECHV. So they are also included on these plans if it's a parents of teachers or NFP agency. And they're reviewed by our steering committee I mentioned earlier, and then we, the agencies, the family support consultants then works with the agencies and gets monthly updates on how they're progressing towards, reaching their enrollment above 90 and then eventually above 95%. We haven't actually built this into our family support data system yet, but we plan to. It's one of the forums for the future. So we're working on that as we build an automated system for our family support data system. And then this is what the data system looks like now. So if you notice, the Excel was horizontal. It just changed in our data system. It's the same fields, it's just vertical. But the plan is, because we have the data of when caregivers and children enrolled based on what the demographic data that's collected in our data system, that eventually, instead of having the agencies manually enter this, they'll manually enter for July, August, and September. And then at the end of September, we'll start doing auto calculations based on the families enrolled as of 10/1. So that should save some time and save some progress on the LAAs having to report this manually, since they are entering the demographic data and performance measure data for all of the families that we're providing funding for under the evidence-based home visiting programs. And then one of the other things we're rolling out this year in July of 2019 is, since we have over 90 agencies and 30 of them are MIECHV LAAs, we do have overlap there, but we're looking at a tiered support system for our family support consultants. So historically what had happened was that our family support consultants were mandated to do an on-site visit every, and there were 2 of them. We just recently had added a 3rd one, mandated to do an on-site visit every year for the length of our contracts, and our contracts are generally 5-year contracts in Pennsylvania for these programs. So we're moving towards a tier system in which we're differentiating the programs based on where they're, where they're at in terms of, staff vacancies and low enrollment. For a tier 1, that would be the highest tier, and it's a little, which they would have the highest need, and it could be because they have a new director or a new leader in their program that's responsible for their evidence-based home visiting, high staff turnover, and if they were put on an enrollment improvement plan, they would have more touch points. So they may have on-site visit, they may have monthly calls. Tier 2 would be more medium level. They would be bi-monthly calls or quarterly calls, depending on the family support consultant and their relationship with the program. And then it would look at if the enrollment's if we're looking at 90% and we're at 89%, we probably wouldn't put them in tier 2. Or if they have long-term staff vacancies, which has been an issue. We're the largest NFP state in the country, so we do have that concern sometimes with the nurses and the salaries and stuff. So we are working on with the agencies to look at sustainability plans and other areas to focus on there. And then tier 3 would be the lowest level of for our agencies. So their enrollment's good, they have consistent and accurate reporting, they don't have any concerns with staffing. They're generally the agencies we've had for the last since 2010 that have been around and have never had an issue would be in tier 3. And they would probably be quarterly calls or every 6-month calls. They're the agencies that don't really need as much touch points, and if they have a question, they'll reach out and ask. So we're looking at moving towards this type of system in order to assist our agencies better and help those who do have higher needs. And then just an overview of the year. So we put out the 5-year plan. So since I said all of our contracts are 5 years, we're looking at a 5-year monitoring plan where the first year will really be about an orientation to our family support program. So we're working on a webinar series that covers stuff like introduction to the data system, introduction to CQI, introduction to program policies, fiscal policies, the policies agencies should have in place, especially if they're a brand new agency under one of our contracts. And then, year 2 would start the on-site visits. So year 2 through 4 would be it would be at least one on-site visit. Not every agency would get an on-site visit year 2 through 4. They would be split based on the need or the what tier they were placed in. And then looking at community collaboration, year 3 we're looking at self-assessments, and then year 4 is transitions for both the families looking at that and referral plans and some of the other stuff there. So we're kind of building on helping the agencies build their local capacities too. And then year 5 it would be on-site visits to the final on-site visit year. And then we've done this with we have Children's Trust Fund grants in our state. We've done this with our Children's Trust Fund grants after the grant has finished. But historically we've done exit interviews with them, asking them like how we could better support them through technical assistance and stuff. So we do plan on doing, after the grant period is over, exit interviews with those programs just to ask questions and see any feedback we can add into the next 5-year cycle there. Thank you.
Okay, great. Thank you, Andrew. All right, Florida.
Hi, everyone. This is Allison Parrish. I'm the MIECHV Project Director for Florida, and I'm just going to share with you a little bit about a learning collaborative approach that we used for building a coordinated intake and referral system, which was to increase enrollment for all home visiting programs in Florida and not just those that are funded by MIECHV. So with that comes some ongoing challenges, successes, and future plans. So this has been kind of a work in progress, I would say. We are a nonprofit, and so we do not have control over any of the state funding that goes to home visits, and we are, don't have any authority over other home visiting programs. So we are funding through our MIECHV dollars, both Healthy Families America, NFP, and Parents as Teachers, but again, we are actually one of the smaller funders. So with that, we thought we would use some of our funding to try to develop a coordinated intake and referral system that would include everyone, which was a pretty big ambition, but it actually has come to fruition. So I'm just going to briefly tell you kind of what the story was here. And so before the CIER Learning Collaborative happened, what has been happening and continues to happen is that there's a prenatal risk screen that's completed by all the OBs, hopefully, and then an infant risk screen that's completed in the hospitals. And historically, those screens would go to the local county health departments, and with permission from the mom, then those screens could be passed on to a Healthy Start home visiting program here in Florida or the Healthy Families teams here in Florida. And those didn't go to any other home visiting programs, and historically there was really no family choice, that basically it was whichever program got to them first, assuming they were eligible, and then the other home visiting programs were left to just try to find families in other ways. And so using some of the MIECHV funding, we decided to do a learning collaborative. And as you can see, we decided to go with our Healthy Start coalitions because they are really a local hub for maternal and child health. It seemed like, there's one in every county. Some cover multiple counties, and it was a good sort of base to work off of because everybody had them. And we had them apply for funding to participate in this learning collaborative, and these were some of the key focus areas here. We're big on continuous quality improvement. This was new to some of the people participating, especially if they weren't part of MIECHV. MIECHV had been doing CQI in other ways, but we were really introducing this sort of new way of thinking, of testing things, using a driver diagram before, where others had not really done that before. So it was really up to the local teams to develop a decision tree that would work best for essentially taking, the pregnant moms and women with young children and coming with a decision tree that would include all home visiting programs and decide at a local level how that algorithm was going to work. It funded staff as well as whatever travel they needed to attend learning sessions, et cetera, and their meetings. And so they would get together. They had we had the model developers involved, so certainly the 3 major model developers, as well as some of the other funders here in Florida, so that we could really get some buy-in to the process, not necessarily knowing where it was going to go, but we said, hey, we're going to try it. We're going to use it, with these 8 projects, try it out, see how it works. And to our surprise, what we hoped would go statewide indeed did. I will say, when I get to the challenges, went a little faster than we anticipated, but the Florida Department of Health, who is the funder for the Healthy Start programs, and the Florida Association of Healthy Start Coalitions, which is where I work, but is really more of a support to the Healthy Start programs, they adopted CIER as the cornerstone for their local systems of care. And so at that time, Florida Department of Health was also overhauling kind of what the standards and guidelines would be for Healthy Start services in general. There were changes to the funding and the way funding mechanisms and the way that was happening, and they just decided, we'll just make all these changes at once. And so the CIER got rolled out at the same time that all this was happening, and I think that I would say it was probably a little earlier than we would have wished in terms of maybe scaling it up, maybe not doing it where it was so many changes at once. But, when the state says this is what we're going to do, then, nobody was going to protest that, because it kind of seemed like we either do it now or we don't do it at all. And so out of that, there needed to be partner engagement, relationship building. Some of the community partners, unfortunately, had not really worked together. Now, I should say, for those that were part of the Learning Collaborative, it was going smoothly. I'm talking now about those that had not been a part of that Learning Collaborative and all of a sudden were told, hey, you're going to do this. So they didn't have that sort of same ramp-up period, time to test their decision trees. It was basically going live, and they were testing it as they are going. And in some cases, they're still continuing to test because we're only a little over a year into it. So they had to really start working together in ways that they never had before. And for some home visiting programs, they were seeing fewer referrals, and in others were seeing more. And so they have had to work those out. Data was an important piece of this, and so FASC developed the Well Family System CIER tab. So they were already using the Well Family System to collect the Healthy Start data for that home visiting program. And now what they've done is to create an additional tab and provider portal so that other home visiting programs, regardless of funding, regardless of the type of the model, are also entering those, basically the referrals that are coming to them, what's happening with those referrals, because we don't want to just have a system where basically it's coming into this, central hub. It's a person that talks to the family, so they get the screen in or a call to their number. They talk to the family. They go through kind of what their different, what they might be eligible for, talk to them through what their options are, and then make a referral to the program that meets both their eligibility criteria as well as their preferences. And so the referral then goes to the particular model, and then that program is responsible for reaching out to her and scheduling an appointment, and then entering that data back into the portal to say what happened to that referral. Did she enroll? Did she not enroll? Did they have trouble finding her? That kind of thing. They also are using it to indicate when they're at capacity. So I've heard people earlier talk about kind of the frustrations that can happen if you're at capacity and providers are sending things to you. And so rather than a provider who's referring, say a doctor's office or somebody else referring, and having to keep track of, all the different programs and whether they're at capacity or not, and then the people, in the programs having to let all these people different know, all they have to do is basically kind of turn off the faucet in this data system. And that way the person who is the CIER coordinator knows, okay, I'm not sending any to this person right now, this program right now, and so they would not even be offered that program. So it actually is much more effective in terms of, being able to offer the family choice, and also to have, a little bit more control over what's available and what's not available. So some of the ongoing challenges, actually the standards and guidelines were recently finalized, and the staff were just trained. So this, it seems like, okay, you launched a year ago, they're just now getting trained. They had some initial training, but there's been a lot of tweaks that have been happening along the way. And, certainly, and then you have staff turnover and whatnot. So this has been really a lesson, learning lesson as they go. And so these are just some of the additional tabs that have been added. there was more training. One of the biggest challenges, I think, is that the CQI has been inconsistent across the state. So like I said, where we had MIECHV, MIECHV programs have been doing CQI since the beginning. They are well-versed in it. They understand it. In other places, if they didn't have MIECHV already, they may not have been using CQI, and they didn't really know the PDSA testing, and didn't necessarily have a lot of patience with testing things to see how they work out and then tweaking them. That just wasn't part of their philosophy. And I think there's still a lot of competition remaining. If somebody's got a lot of vacancies and their funder is saying they need to get their enrollment up, then they're going to get a little frustrated with the process if they're not getting more referrals. And so that's in some cases people have again seen a sharp decrease in their referrals, and in other cases it's actually increased. What we're really trying to do here, though, is to make sure that it's balancing out to where everybody's getting sort of the right amount of referrals, and part of that may be that we need to increase the number of referrals coming into the CIER system. And so I'll get to that in just a minute. So we continue to have joint troubleshooting at the state level, ongoing communication at the local level. There's a local advisory group, there's a state advisory group, and we kept on a consultant through the end of this September to really be able to provide technical assistance to guide the group. There's also a best practices group that is trying to see what's working best and to share that with the other counties. The Home Visiting Advisory Group includes the model developers, the funders, partners at other state agencies that have a vested interest. And I would say also just for Florida MIECHV that our capacity remains high. We continue to have around 89–90%. Part of that is I'm sure that we're also doing CQI around, and have been for a long time, around home visiting and retention, and that maybe is a presentation for another day. But we have continued to do well, but we also want to see that this works for everybody. So future plans and wrapping up, just that I will show you in the top right-hand corner. This is our branded Connect is what we're calling it. So rather than CIER, because that's not really very good for families, we're calling it Connect, connecting families to community programs. So we want to brand to increase awareness of the new process, to really, ideally have families calling us instead of us calling them, so that we're not just relying on those screens. And just really making sure providers know they refer to this sort of one-stop shop, that they don't have to know all the different eligibility. And also that we're working with our state partners and other sponsors to really try to market this in a much larger way, so that everybody will know about it. And so this is a link to where we can find more information. And I apologize for talking fast. I had a lot to go through in a very short period of time.
Okay, thank you so much, Allison.
So I'm going to turn it over to Georgia, Natasha, and then I'll answer the question in the chat box. Thank you.
Thank you.
Thank you, Allison. I'm Natasha Worthy, and I'm a Senior Program Manager for the Georgia Department of Public Health Home Visiting Program. Maximizing caseload capacity through contract monitoring in Georgia MIECHV. Why focus on capacity? The Georgia Department of Public Health, and you'll also can be referred to it as us as the state leadership team, inherited the caseload capacity for our local implementing agencies when we began to manage the MIECHV program in 2017. As the department focused on establishing a smooth and stable transition during the first year of implementation, the subsequent year, we focused more on developing a relationship with respective sites through our sub-recipient monitoring process. Through this process, we identified issues and concerns related to caseload capacity that affected our parent educators, the achievement of our CQI goals and objectives, which were around family engagement, and caseload capacity also had the potential to affect our state successfully meeting the capacity recommendations of our HRSA and MIECHV funders. Georgia's contract monitoring process includes monthly reports, bi-monthly calls, and annual site visits. The monthly reports provide the state leadership team with details regarding staff vacancies, number of families enrolled, case closures, program financials, and also the number of available slots that site has. The bi-monthly calls deliver the opportunity for the LIAs and the state leadership team to discuss the information provided on the monthly reports, to share progress, success, and to discuss any challenges. The annual site visits offered face-to-face contact to discuss the items covered during the year, as well as to provide technical assistance, provide an overview of the financial documents from the site, and gave us the opportunity to spend time with staff and on some occasions to meet the families served. As a result of the contract monitoring process, we were able to identify and address concerns and issues that related to capacity. We learned that some sites were carrying more families per caseload than recommended by the model, and others were not nearly reaching the recommended caseload capacity. Some of the LIAs shared that carrying the maximum number of clients when working with high-risk populations was not always realistic, especially when you're factoring in that you need extended time to work with that population, in addition to time for documentation and other work responsibilities. This, we found, led to staff burnout and staff turnover. The staffing concerns revealed capacity was also being affected as a result of our LIAs having extended staff vacancies. Based on the information gathered through our contract monitoring, the state leadership team reviewed the inherited capacity goals as well as internal policies and protocols. We found that we were giving inconsistent messages as the state team as it relates to capacity. In terms of our contract, we have 80, but our expectation was for them to reach the goal of 85%. And we also had no standardized way of assigning capacity to the LIAs. Therefore, we needed to develop and define capacity that aligned with the federal definition and develop policies and protocols to support that. We worked with the home visiting evidence-based models, the Georgia Leads, who provided TA assistance regarding the feasibility of the inherited capacity goals using the Early Head Start home-based model, Healthy Families America, Nurse Family Partnership, and Parents as Teachers. We also received federal assistance from our project officer who supported our efforts and approved technical support from the Education Development Center Home Visiting Improvement Action Team. The HV Impact representative provided our team with information on what other sites around the country were doing, as well as providing guidance and support throughout the process. As a result, we received approval from our project officer to implement the following protocols. Our capacity goals for each LIA based on the number of home visitors that they have is 85%. Our Parents as Teachers model will require that those part-time staff serve 20 families and, part-time staff will serve 10 families and full-time staff will serve 20 families. We had no changes in our Nurse Family Partnership or the Early Head Start home-based option model. Healthy Family America for part-time staff will be responsible for 7 families, and the full-time staff will be responsible for 18 families. Our LIAs will have 5 months from a staff vacancy to hire, train, and to build a caseload for their new home visitors. The Georgia Department of Public Health will implement an incentive program because we want to award and recognize those LIAs that are meeting the 85% requirement for at least 9 months. Next steps, we plan to develop the incentive program. We are planning to update all of our contracts and monitoring tools to reflect the new policies and we're going to officially inform our site, or we have informed our site officially of the new change, which is projected to start October 1st, 2019. If you have any questions, you can please put them in the chat box. At this time, I'll turn it over to my colleague, Carla, for her to present.
Good afternoon, everybody. Thanks for being on the call and hanging in with us, and these great questions are coming up, and I appreciate that. I just wanted to catch you up a little bit about Tennessee and what we're doing here. We have evidence-based home visiting programs currently in 57 of our counties. We use 3 models: Healthy Families America, Nurse-Family Partnership, and Parents as Teachers, with primarily Healthy Families America being they're 95% of the programs across our state. We are looking at some potential funding that will increase us by 17 additional counties, and at that point we'll only be 20 counties out from being able to cover the state with home visiting. So we have a lot of opportunities to see what we're doing and try to figure out how we can do things better. We used a multi-stage CQI project. You know, we can either guess it or we can try to get the data to make good decisions. So we worked on a variety of ways of gathering information. I'll kind of flip through that with you because of time. But we looked at the reasons that for program exit as cited by the participants. And you can see there that the largest percentage there is that loss of contact, we couldn't locate, moved out of state. Families, though we did have a great number of families who successfully completed the program. So that gave us the beginning of data to start to look at our CQI work. The second thing we did is really look at a cause and effect diagram for retention. So why do families exit the program then before graduation, trying to come up with all the pieces of cause and effect and how that happens. Then finally, each of our agencies, we work together in a consensus workshop kind of fashion, and we are very fortunate that we have an epidemiologist here whose focus is entirely on CQI. And agencies chose various projects. They looked at things like incentives, look at their enrollment criteria. You can see all the kinds of things that they looked at. You know, did a lot of work for a year. We did, quote, a lot of follow-up on that. As a result of great work, I wished I could say everybody was super successful and every one of those projects just rocked it, but that didn't actually happen. Some were very successful, others could not see any change in the work that was done. But on this next slide, if you look, we see that we had great improvement. We went from 9.6 months to 12.6 months today. And that happened irregardless of whether those projects were successful or failures. Some of our projects, some of our sites bring up everybody's average, but we started to understand that everybody didn't think of CQI in the same way. So we decided to go back to the drawing board and think about it from a different perspective. Why are we not achieving these goals, performance standards, and why are we not seeing improvement in our performance outcomes? And the first thing we realized is not only did our LIAs and our partners and other evidence-based home visiting programs that are not MIECHV funded in the state, we all saw it differently. So we began a process in which our epidemiologist is working on a kind of a continual improvement university. First, she's working with us here in our central office to look at how we do business, looking at sustainability and alignment. Central office and our EBHB providers are starting to now think about it and begin this process to work together to define what CQI is, to understand that, to look at our processes, see how we build on them, and how that we can make a system that contributes to the productivity. The second piece that's made it difficult, and you maybe have experienced the same thing, is we need it to be stabilized regardless of who the players are. At our central office, I'm the third MIECHV director in the past 6 years. Our office staff have had some turnover, and every time a new player came on board, there wasn't a process out there that helped direct us. So we're really working to put consistency in how we do this work and how we play this game. The biggest thing that's making a difference for us, that's kind of a pivot piece for making a CQI plan and asking each one of our LIAs to have a champion, and that champion will then come together and work for the next, I believe it's 12 to 14 months with us. And instead of you dividing a project for your particular LIA, they're going to work together in project teams on areas that they feel they should focus on. So we may have we'll have a mixture of LIAs working together. The second piece of that is we realize as part of our CQI that we need more parent voices, and have started to work on some parent focus groups, and out of that have looked at parents who have a very active voice now and would like to have a more active voice as time goes on. So we're bringing in parent voices and a parent advisory council for us. So those kinds of things have been the biggest pieces of what we do. The last thing that's happening that this fits in nicely for is we have a new process here that we, being the Department of Health with all 95 counties, we have a new initiative called CHANT, which brings together, we use referral sources from our birth files. So for every baby that's born, they are looked at using the parameters not only of MIECHV, but some infant mortality algorithms, and we look at their level of risk. So the families who are high and medium risk get a phone call from our call center offering them services through the Department of Health's CHANT program to meet the needs that their family identifies. There are also those families with newborns who are eligible for evidence-based home visiting service based on our criteria are then given to the corresponding EBHV program in that county, and they contact this new family and offer support services. So we're already seeing, it just is rolled out into our EBHV programs, we're already seeing an increase in the number of referrals that we're able to reach families within that second week of birth and offer them services. And that fit right in with our CQI performance plan on how do we retain, how do we keep it going, and what's the work we need to do. So beginning now, we're looking to the next 18 months. Maybe we can give you a report at that point in time on how we've done with our continual improvement university and the projects that we've undertaken.
Hey,
Anybody
thank
any
you
questions?
so much.
Just type them in the box and I'll be glad to try and answer.
Yeah, please do enter any questions for our presenters. At the same time, we're going to bring up our CQI poll. We have just a couple short questions for you, and then our final slide will be after that. So Kate and April, could you please bring up the questions? So we'd like to ask you if you'll take an action step based on this webinar, yes or no. And if you will be taking an action step, if you could briefly describe what that would be. Or if you're not going to take an action step, what would have helped you in identifying a future action step? We're constantly looking to improve and make sure that our resources are most useful to MIECHV awardees. So please do take the time to fill in our poll and give us some suggestions of what you will take from this or what would help you be able to take things from future webinars. So I'm just going to allow about another 30 seconds for the poll, and then we'll transfer to our final slide. And after the final slide, you will have an evaluation pop up into your browser, so we would ask you to take just a couple minutes and fill in the evaluation. Just about 20 more seconds on the polling before we move on. About 10 more seconds. All right, if you could just leave the polls there, Kate, and advance the slide to the final slide in the deck, then I will be able to just kind of wrap up as everyone's still entering in some information. So I just want to thank you all for attending today. Thank you to our presenters. They did an excellent job of pulling together very succinct, important information and presenting it in about a 10-minute time block. So If you have follow-up questions, please don't hesitate to reach out directly to our presenters. You can see in the file share pod, when we close this, you'll see that the slides from today are already available for your download, and they will also be available on the HRSA website, which you can see on this slide. Our next webinar will be on father engagement. It will be on October 15th, and we will again feature some of our awardees and the excellent process that they are going through to advance father engagement in their own programs. So finally, I just want to say thank you on behalf of HRSA and HV Impact for attending today, and I hope you have a wonderful rest of the day. Please do take a few minutes to fill in the evaluation. Thank you.